Uh, Yesterday we discussed about the CTEV, its clinical feature, investigations, and how to check whether the CTEV is present in a child or not, and about the management part, the two methods of correction. The main principle of management of CTV is first to achieve correction, and then second is to maintain that correction. And the ultimate goal of this aim of treatment is painless, flexible, mobile, plantigrade foot. This is the ultimate goal. And coming next on to children who do not respond to the conservative management, either either because of the uh, the child has not taken any treatment, that is neglected or are not presented, or this is neglected clubfoot, or the deformity was not at all corrected by, not at all, any component of the deformity was not corrected. This is resistant. And third variety is relapse and residual deformity. These are the three indications of the surgical management. And the relapse is, first there was deformity, then it was corrected, amenable to correction with the conservative management, with manipulation, and then patient has either discontinued the treatment, and in due course of time the deformity has relapsed, it has returned back, or some because and some of the deformity may not have been corrected, that is the residual deformity. Now coming on to what is a relapse and neglected. Relapse is initial correction done and subsequent deformity is less severe. Neglected deformity is severe and worsen, a child starts walking. This is neglected. They have not taken any treatment. And this is usually in post-surgical patients, extensive scarring and stiff foot. And in neglected, you find skin callosities and fissures on outer and lateral aspect of the foot. Now, what will we do in surgical correction? Surgical correction is the within from first the child is managed with conservative management, and when you call a neglected clubfoot is minimum of 9 months to 1 year. 9 months to 1 year, the child has not taken any treatment. He has not seen any of the uh, medical care for the foot deformity. Then it's said to be neglected. And once the child starts walking, the deformity progresses gradually and bony changes they ensues. They got into the bony deformity, they got into the foot. And the treatment is for first 2 to 4 years is soft tissue release. And if the child is more than 4 years, we have to go for bony procedure along with the soft tissue release. Bony procedure along with the soft tissue release. And if child is more than 11 years, either we have to go for their only bony procedures. In soft tissue release, what we do in soft tissue release, what is the extent of release? It depends on the type of deformity. If the deformity is equinus, pure equinus, then we have to go for posterior release. Persistent isolated equinus, we have to go for posterior release. That is, posterior side is tight, contracted. And for the complete club foot, we have to go for posterior as well as medial. Posterior as well as medial, uh, and plantar release. Only if all the components of the deformity they are present. Now, the incisions. Students, please mute your mics. Incision is described in books as Turco's approach. It's a hockey stick posterior medial skin incision and it crosses the skin crease on the medial side of foot. Some uses Cincinnati incision, which is all along this posterior aspect, from medial to posterior, then to lateral, along the circumferential. This is inverted hockey. This is hockey stick type of incision. What we use here is two separate incision. This is continuous single incision. What we use here in our institute is single posterior incision and single medial incision in two parts. And it's more difficult to reach the sterolateral structure in this medial incision. Incision along the tendo achilles and above the joint. Tibialis posterior can be released in this. Then Cincinnati approach, this is the incision in the medial, then this is posterior, and this is on the lateral aspect. You don't need to go into further detail of this, you just have the name. Then the two incision approach, medial incision, straight oblique incision first, metatarsal across the medial malleus and to the Achilles tendon. And emphasis is there in the on the plantar release and capsulotomy of the joints. Posterolateral along the lateral side of the heel cord, and most important is posteromedial release. What we do in posteromedial release is three joint: subtalar joint, talonavicular joint, and medial navicular-cuneiform joint. This is calcaneocular joint, capsulotomy. What we do in subtalar joint, we leave the interosseous ligaments intact. And on the plantar aspect, we release the knot of Henry. What is knot of Henry? It is crossing over of the two tendons, flexor digitum longus and flexor hallucis. Then decrease the abductor hallucis. Then lengthening of the tibialis posterior tendon. The most important pathological feature is tightness of tibialis posterior. Lengthening of tibialis posterior is most important. Then plantar fascia if cavus is present, and spring ligament and bifurcate ligament. Most important, you must know what are the structure which has to be not to be cut. The question asks are what are the structure which are not to be cut. You have to preserve the neurovascular bundle, deep deltoid ligament, and dorsal structures which are there on the tibialis anterior and extensor tendons, which are to be kept intact. What we can do in posterior release of posterior capsule of ankle and subtalar joint, open tendo achilles lengthening, and posterior talofibular ligament. These are the ligaments we have to release in posterior release. Lateral release is most important is calcaneofibular ligament. Most important is calcaneofibular ligament. Others you don't need to remember. And lateral subtalar joint capsule. Subtalar completely the of the backs, calcaneofibular and lateral subtalar joint. Then after releasing, we have to fix the foot in corrected position. We have to fix the foot in corrected position for talonavicular joint, often with the subtalar joint. Then comes the talonavicular joint. as already told, if the deformity is dynamic, that is persistent varus and supination during walking. Walking there is persistent supination. That will require tibialis anterior transfer, tendon transfer. This is the tendon transfer. This is performed between the child of 3 to 5 years of age. This is also a question in easy entrance. Uh, just hold for a minute. The deformity is dynamic deformity, and it is best performed within the 3 to 5 years of age. Insertion of the tibialis anterior should be on the cuboid on lateral side, lateral cuneiform, and it does not require any bracing after the procedure. This will lead into correction of the dynamic correction. With the movement of dorsiflexion, the deformity will be corrected. That is, the lateral aspect of the foot will be lifted up. That will correct the foot into plantigrade fashion. But at the postoperative complications, there may be loss of correction, there may be loss dorsal subluxation of navicular or cavovarus deformity, valgus overcorrection. There may be bunion formation or hallux flexus, and it can be treated by capsulotomy or lengthening of FHL. There is flexor hallux flexus is treated by lengthening of FHL. Then when the growth changes, they have developed into the bony segment of the foot. So soft tissue alone may not be fully correct the deformities. Then we have to go for bony procedure also, as the secondary change into the bone morphology has taken place, and the combination of this soft tissue release. So we have to use the combination of soft tissue release with midfoot osteotomies. That is required in child between the 5 years to 12 years of age. Adductus, forefoot adductors, the lateral bony column is longer than the medial column. So relative lengthening of the lateral portion of the anterior process of calcaneum, there is lengthening, and there is obliquity of calcaneocuboid joint, which is causes the lateral longer bony column. The bony column of the foot, lateral bony column, that is fourth and fifth metatarsal, cuboid, and calcaneum, they all are lengthened, and medial side is not growing at that same pace. So procedure described is Lichblau procedure. Lichblau procedure, the excision of anterior process of calcaneum is removed, so lateral column is shortened, and this is closed wedge. We remove the bone of wedge and close this wedge, so lateral column will be shortened, and this does not involve the articular surface and preferred in younger children. The bony procedures, they are not to be done before 5 years because that can cause shortening of foot. And next procedure is Delevingne-Vaughan osteotomy. And with this calcaneocuboid wedge resection, this is the resection of a joint. And once the joint removed, both the bones, they are fused to form a single calcaneum and cuboid. So this is arthrodesis of the joint. There is reduced risk of relapse. Chances of relapse are less. And there is stiffness at the midfoot joint because we have fused one joint, and this is preferred in older children. And what is most important benefit of this, that it can be combined with soft tissue release, and there is complete correction. These are the various osteotomies. This is the best to be resected in the cuboid. This is the Lichblau, which calcaneocuboid resection. Lichblau is this. This is Lichblau, anterior aspect of the anterior part of the calcaneum. This is the resection of calcaneocuboid joint. And this is decancellation of cuboid, which we performed routinely. We remove the cancellous part of the cuboid and get it collapse, and this decreases the overall lateral column, and the joint they are also not much deformed. Transmetatarsal osteotomy, they are for the cavus deformities. For the cavus deformities, metatarsal osteotomies they are for cavus deformity, and then correction of equinus. We have seen the correction of uh, adductus, and now correction of equinus. Equinus with lateral column shortening, excision of a portion of head of talus and navicular bone. So the final resort is to consider adding a distal tibial dorsiflexion osteotomy. Usually soft tissue correction can lead on to this, but for a bony procedure, we need to remove a portion of the head of the talus or navicular. The calcaneal varus, persistent calcaneal varus, a lateral slide osteotomy of the calcaneum. Calcaneum is cut here, and this is the wedge is removed from the lateral side. This is lateral side bony wedge removal. The incision is parallel to the septal joint and Dwyer's lateral open wedge osteotomy. Dwyer's lateral close wedge. We have to remove a wedge from the lateral side because there is consistent varus. Varus means lateral aspect is grown, medial aspect is not grown. So we have to remove a lateral aspect of bony piece and close it. So this is lateral column shortening of the calcaneum. This is the how the calcaneum is, and we remove the lateral based wedge, and this is correction of heel varus. Now salvage procedure in older children about 12 years of age. The salvage procedure for pain and after various previous surgical procedures. We have done various surgical procedures of soft tissue release and other bony procedures, and it has not lead on to correction. Then this is the salvage procedure with triple arthrodesis. One single shot procedure after surgical maturity, after the skeletal maturity, is triple arthrodesis. This is the question usually asked in NEET exam. And what is the benefit is correction of large degree of deformity in the neglected cleft. You can go for this. And it is not performed before the advanced skeletal maturity because this can lead on to deformed shortened foot. Foot get shortened. What we do in triple arthrodesis, this can be 2 stays or single stays. Bony in 2 stage procedure, bony resection is minimum, and in single stage there is reduced risk of avascular necrosis. What are the joints? This is talonavicular, calcaneocuboid, and subtalar. These are the joints which are there. Another important method is Elizero. Elizero is a Russian Gabriel Elizero, Russian scientist, Russian orthopedician, who has developed this technique, and correction slow enough to protect the soft tissues. This is slow, gradual correction. The bones, they behave as viscous fluid, viscous gel under the traction, and correction at the is there at the focus of the deformity, and simultaneous correction of all the 3 dimensions, multi-level correction can be done, and deformity correction can be without shortening of foot. Usually, bony deformities, once we correct, there is shortening of foot. So we can go for correction without shortening of it. The rings are to be fixed to the tibia and connected to calcaneum and forefoot. This you don't need to remember all these things. This is how the procedure is taking place. This is the ring. These are the rings applied in the found foot. We do the bony procedure. This is how the appearance of the apparatus. This is the apparatus. This completes your chapter of congenital talipes equinovarus. Now, if you want, we can go for uh, uh, the next topic, that is congenital dysplasia of hip, CDH. So now let us start the next topic. Wait for a minute.